Everyone. Rheumatic fever starts right at the beginning of our patient's journey. And the community health workers visit the patient and their families on the ward to explain what our role is within our rheumatic fever team. And if appropriate, we establish family links and we explain our backgrounds and cultural connections and whakapapa, which is genealogy. Some of our families would like to know that sort of information, and we more or less go along with it because it helps to form relationships and link us into that family right at the beginning, and especially if they want it. Sometimes English may not be the first language for the family, so getting alongside them is really important to help build long-term relationships on respect and trust. Education by this time has already been started by the staff, and we reinforce that. We review parts of the booklet that we have here today, and we try to gauge whether they've got clear understanding, keeping in mind that simplicity in small amounts is often the key for our families. These books were designed, and huge input was made by the families and the children themselves, and we just help with the information within it along with their okay. The community health workers, when visiting the family and the patient and the family on the ward, we talk about throat swabs, prevention and protection for other members of the family and for other members of the extended family, and that if they would like, the community health worker can visit them at home and do throat swabs for all the family. And we arrange that while they're in hospital with the parents, and once the child goes home, we then visit them at home and speak and use that opportunity for extended family for more education. We also attend family meetings because the patients are usually in hospital for a period of not more than 2 weeks, and family meetings are arranged for them prior to discharge, where the first penicillin injection is arranged, and any issues that the family might have are addressed, and we make sure that we help as part of the team that's in the family meeting. We help to make sure that the transition for the family, for the patient, is as smooth as possible from the hospital into the community. Once the patient goes home, we use this as an opportunity to say, well, remember those throat swabs we talked about? Would you like me to come home? And we make arrangements for that to happen with the other members of the family, so that when they come, we use that as a golden opportunity to talk about why we do these throat swabs, why rheumatic fever is quite preventable if all sore throats were swabbed in the first instance. And while we are doing the throat swabs, we explain all this to them and say that when in 3 days' time I will ring you back with a result, and if there is any positives, I will suggest that you take that child to your family doctor to get some antibiotics. And antibiotics will have to be taken for 10 days, twice a day. And would you like me to help you with that, to remember them? And then all those choices are left up to the family to make. And one of the things I do always say is, I probably need your help more than you need mine, because I would like you to use the information that you have to protect other members or other connections within your family that aren't here today, so that they take on a fair amount of responsibility of sharing the gospel, as it were.
Part of the district nurse role is to build a good relationship with the patient and the family. Part of the district nurse role is to build a good relationship with the family, and continuity of care, especially in the young patients, is very important. Oh yes. District nursing give all the injections, and we try to build a good relationship with the family. Continuity of care is very important, especially with our young patients, to gain their confidence. We do a comprehensive nursing assessment using the rheumatic fever guidelines, and the learning needs are different in different ages and different cultures, so we establish their knowledge base using our rheumatic fever healthcare education plan, and we also check if they have a dental card and if they have the rheumatic fever booklet. We have many resources. Our assessment and care plans are updated every year, and PRN if necessary. The healthcare plan is updated every visit if need be. We collect compliance data every 2 years on the even year, so this year is the year, and that is collected by all the 3 DHBs in Auckland. And the result of that collection of how many injections the patient gets, whether they've had them late, the triggers are there, whether the patient has been to the dentist, when the next dentist visit is due, when they last went to the rheumatic fever clinic and when that is due, and if we need to get an appointment, we ask our community health workers to arrange that for us. And the ethnicity is also documented. And at the office where I work, we have 259 rheumatic fever patients.
Can I just ask you a question?
Yes.
Do you produce the booklet in other languages, or is there no need to do that?
No, we don't. There probably isn't a need, because there's always somebody in our families who speak English.
Yep.
Yeah. And if there wasn't, there would be one of the community health workers who could speak in their own language. In Counties Manukau we have 4 resource nurses. One is attached to each base, and we all attend the Auckland regional meeting along with the other nurses from the DHBs. And that meeting is to support us, to discuss any concerns, any policies, any patient care, to liaise with the paediatric cardiology specialist nurse, and the clinicians are also there. Our clinicians, we're very lucky, are very accessible to us. That we will phone them if we have a problem, we will email them. Our techniques are, as you see, early intervention is the key. Right from the diagnosis in hospital, you have to get in there with your education, with your community health workers, the culturally appropriate community health worker, the community approach with the district nurse giving the injections, and the collaboration, which is that slide there. It all starts from the hospital to the rheumatic fever register to the community health workers. the district nurses, we are part of our home health care. We're a multidisciplinary team. The GP is in the loop. The school nurse and the public health nurse gives us support. The rheumatic fever clinic, as we've talked about. Our cardiology adult patients go to Manukau Super Clinic for their appointments, and the children go to Auckland Starship. Dental treatment up until the age of 18, if the child is at school, is free. Other than that, it's expensive, and we give them one of the dental cards, as you have already read, which is to prevent endocarditis. Yeah. And as you see, if there's a break in the spoke, the ride will be rough.
Can I just ask about when you're swabbing your siblings or others? Yeah. Do you explain to them about resistance if they don't complete their course, and the fact that if they get a sore throat again, they need to go to the doctor? And okay, I just wanted to clarify that.
Very much so, yes.
I'll just go a little broader and talk about some concepts of education just in a couple of slides, just to get some discussion started. Rheumatic fever, rheumatic heart disease is a huge issue, and I think we'd all agree that really the amount of information that we would like people to know, that's just a few things that I can think of. I'm sure you can think of some more. It's an overload, it's an information overload, or it can be. If everybody understood everything we thought they needed to know. So, what's important? Let's argue for a start that maybe having people recognise their own signs and symptoms and come in for management early, understanding the importance of secondary prophylaxis and understanding what the disease at various stages means to themselves, maybe we can decide that that's the most important thing. Maybe not. What's relevant? Okay, now people are coming in to present to a health service at various stages of their disease. Some people are coming in early with rheumatic fever, some people are being diagnosed with severe heart disease in pregnancy. What is relevant? So we've got this information overload. Maybe we can pull out what is relevant at the time to that person. I've just pulled out some things here. For example, this person's having surgery, so maybe these are the important pieces of information for this person to know. There's a lot we could tell him, but maybe this is what we should be telling him. Again, Jay was talking earlier about pre-pregnancy counselling. Maybe this is the most relevant information that we should be giving to young women, or this particular young woman. This is all up for discussion. I'm just throwing some ideas out there. So there's a lot of information, and the other thing is, when do we do it? We have opportunities at diagnosis. What should people be what sort of information should they receive at diagnosis? Do they need to know about the complications of surgery, or do they just need to know that perhaps surgery might be a risk for them? When they receive regular secondary prophylaxis, what sort of information should they be receiving regularly with secondary prophylaxis? What sort of information should they be getting when they see the doctor every 6 months or 12 months? What sort of information should they be getting pre-op? Should they be getting information about not being able to have children very early in the piece? Maybe that's a potential. I was just telling the last group that in Fiji, a good bargaining tool for Indo-Fijian people especially, who place a lot of importance on the young girls having families, the family are very concerned that if this girl doesn't get good treatment in early stages, she won't be able to have kids. That is a very important tool. That is education that they need very early on in the piece. This is, just to finish off, anyway, just some ideas. This is a photo of Dr. Joe Cardo in Fiji, who is a paediatrician. This is a lovely photo of him teaching a doctor and a nurse about rheumatic heart disease, and this young girl who was newly diagnosed came along to our training workshop and agreed to be interviewed very shyly through her mother. And this is Joe teaching her about her own heart and also teaching the doctors and the nurses at the same time. I personally believe that educating patients needs to occur through educated health workers, and we haven't really addressed that, so I'd be very keen to hear about what you think about all those issues. We can talk about any of that, and I'll just bring up the girls' wheel because that's kind of a good one. It's got various stages and various players. So there's a few ideas and a model that seems to work. Does anyone want to comment or have experience? Yep.
Like in Australia,